that. Thank you.
Thank you. Thanks, Karen. And thanks, Alicia. You guys have been amazing putting up these talks, and I've heard they are so important, and patients and their caregivers love them. So thank you for what you do, and we all love doing this. It's very interesting for everyone. So my name is Hamza Habib. I am a pain physician. I'm primarily a palliative care doctor who has specialized in pain management and surgical pain management for cancer pain. We take care of a lot of patients here at CINJ in the outpatient department. We manage their medications, we offer procedures when need be, and in addition, we provide a lot of support from a pain and symptom standpoint for mood, for anxiety, for depression, for nausea, vomiting. So that's me. We have Maura here as well.
Hi, everyone. My name is Maura Goots, and I'm a RN here at the Rutgers Cancer Institute. I work in the clinic with Dr. Malini Patel, primarily caring for patients with head and neck and lung cancer. And I'll be chatting a little bit about some integrative methodologies that you can use for handling your pain. Thank you.
Good, wonderful. So that's me. We'll talk a little bit about the basic assessment and management of pain. Next slide, please. There are no active disclosures that are related to this presentation or anything that is talked about in this presentation. Next. So all right, so this is the fun part. So I got a lot of emails from a lot of people. Some of them may be here. Is how do you perceive pain, right? I mean, there's always this question that where does pain come from? So this slide kind of tells you about where the pain comes from. So let's say one day someone is walking and all of a sudden they step on a nail. You see that big foot at the bottom? So basically, in once you step on something, you see those two things going up, a red and a blue one. Those are little nerves. They go all the way up into the spinal cord. You can see they climb all the way up into the brain. So they go into a couple of places. Number one, it goes into a place of the brain in the center where it perceives pain, and you are like, you feel the actual perception of pain. The other part it goes into is your mood and anxiety and depression areas. And what happens is that, if you may have seen, that people who have chronic pain, they don't do well with their mood either, because we know that pain, when it's persistent, that can affect your mood as well. And it is because if you see up in the brain, there are all these things, these pain pathways are connected, right? So that is what happens. The third thing that happens is that when it goes into the spinal cord, when you step on something, you kind of pull your foot back, because that's a reflex, because you don't want to hurt yourself more. So pain is just not the perception of feeling bad. It is the perception of anxiety. It affects the perception of anxiety. It affects the perception of depression. It affects your mood. There's also a link, when you step on something and you say a curse word, well, guess what? There's a connection there. It's not you guys. It's your brain. And people have different preferable words. I'm not going to say them out loud. But this is what happens. The brain is connected and wired in different ways, where different things happen in different places. Next slide. So let's just look at this in a different way. Let's say that there's a trauma. You see that this little bang sign at the bottom, right? So right there, let's say something hurts. All of a sudden, the nerve goes up and takes the pain up into the spinal cord. You see that little gray thing? Takes it up, right? Goes up, goes up, goes up, great. And it goes to the other side of the spinal cord. And then it goes to the brain where there's a bang, there's pain, right? There's a whole pathway there. Now, the idea is that pain is perceived in different areas. One process is called transduction. Let's say someone hurts their foot, right? You can put a little local anesthetic, LA, that's what it says there. You can put a little capsaicin there as well. So capsaicin is one of those like little icy hot things you can put up there. You can use something like an NSAID, like a Tylenol, or not a Tylenol, like an ibuprofen or an Aleve, if you can tolerate that, right? And let's see that now the nerve is going up into the spinal cord, that area, right? Transmission, that's where we can do nerve block. We can block the nerve that goes from the leg all the way up to the brain, right? So the pain is not perceived there. So that's another way of controlling pain. Then the pain goes further up, right, into the spinal cord. It's entering the spinal cord. Over here, exactly there, we can actually use something called as alpha 2 agonist. This is another kind of medication that we can use for pain, right? And then further up goes into the other side of the spinal cord, goes into the brain. So here we can use different antidepressants, anti-anxiety medications. We can use different narcotic pain medications and a lot of other things. The idea is that we can block pain in multiple levels. We can block pain in multiple areas. So the idea is that we just don't have to use one medication. We can use 6 or 7 different kinds of medications, each one of them doing different things, and control the pain optimally. And this is the model of pain that we follow when we come to someone, especially in cancer. We try to block pain in multiple areas. Next slide. So why do we like to treat pain? Like I told you, right? Here's what happens. You get pain, your brain has those connections that I showed you. What happens is that those pain signals, they get sent into those little areas. People start getting anxiety, depression. What happens when people get anxious and depressed? They don't sleep. When they don't sleep, especially in older people, right? What happens is that they get confused. And this confusion and this lack of insight, what happens is that they don't walk as much. Their physical activity decreases and then they start falling. So it is a cycle that we see most often in patients, especially who are older, who've got chronic pain. So that is why when you go to a pain doctor, what they want you to do is they want you to go to a physical therapist so that you can do physical therapy. They want you to manage your pain to be managed in different ways. I mean, in addition to the pain medication, they will add something like an anxiety medication, like a mood medication, like a sleep medication. So a lot of things are added. So that is why we treat pain, and that is why we try to prevent a lot of other badness that comes with pain.
Enter your meeting ID followed by pound.
All right, so next slide. So how do we select a pain medication? How does Dr. Habib scratch his head and think, well, this medication is going to work for you? So there are different patient factors. What has worked before for a patient? How good are their kidneys? How good are their livers? Is there something else that they have? Do they have anxiety? Do they have depression? Do they have nerve pain? Do they have headaches, right? So we look at a lot of those factors before we decide on a certain medication. Then we look at the medication factors, right? Can this drug go to someone's back and help with the back pain? Can this drug go and help with back pain and mood at the same time? So different drugs do different things. And there's another factor is that can this drug give a side effect that is going to really badly affect this patient? So that we look at the medication factors. The third factor is the disease factor. We look at the disease. Like, is this disease going to be affected by this medication? There are some studies which have recently shown that patients, especially with lung cancer, their disease gets worse faster if they're on a certain form of morphine. Now we also look at those factors. We look at, like, is this disease, let's say someone has diabetes at the same time, can we control their diabetic pain with that thing? So there are a lot of decisions that are happening when you go to a pain physician. They're thinking through, okay, what will work, what will not work. So that is how we select pain medications. And I know a lot of people don't like their pain doctors because they don't select the medication they want. So I just want them to understand that this is how the process goes through. It goes through multiple levels, and then we come up with an idea, okay, this is the patient medication that will work best for the patient with the least side effects and the most benefit, knowing the whole picture at that point. Next slide. So the first thing that I like to use for anyone, especially if they are non-cancer related patients, is I think about very basic things. Tylenol, right? If someone doesn't drink a lot, if someone's liver is fine, we use Tylenol or acetaminophen, that is the ingredient in it, as the first line drug. It works really well. It is very well tolerated in most people, and it has very less side effects compared to some of the other medications. So the only thing that we look out for is we tell people don't drink a lot, number one. And number two, if there's other medications that you're taking which have acetaminophen or Tylenol in them, sometimes they're mixed up in cough syrup, sometimes they're mixed up in other pain medications. So make sure that you do not go above 3 grams or 4 grams per day. Usually I like to say 3 grams from all sources of Tylenol and acetaminophen. So that is something that
Yeah,
we
good
like to really
afternoon.
look forward to.
You know, Vale, na school they say what to say to me. I said I look.
The other thing that we can use is second line medication, which is like an NSAID, right? NSAID, NSAID stands for a word, non-steroidal anti-inflammatory drugs. So basically, they're not steroids. They decrease the inflammation. Remember that foot diagram? When you step on a nail and your foot gets a little inflammation on where you step on a nail, that is where basically this medication works. It decreases the inflammation. So basically we use these medications. The only thing that I ask patients to be careful about, like we do in Tylenol, in this medication class, we worry about having heartburn, having gastric ulcers, having issues with bleeding, right? It can cause some people to have their blood pressure go up. That's an issue if they're on blood pressure medications, right? We tell them that drink a lot of water with that. Make sure that your kidneys are not bad to start with. Don't use it for a long time. So the medications that are NSAIDs like ibuprofen, naproxen, Aleve, Advil, Motrin, all of them, we try to make sure that people don't have kidney issues, they don't have heartburn, gastric ulcer issues, and they don't have bleeding issues, or their blood pressure doesn't go crazy with these medications. And if everything works out, this is a very good medication these are very good medications that work really well for short-term musculoskeletal pain. Next slide. Now we come to the big guns. Let's say Tylenol is not working. Let's say Advil, Aleve, and all those things are not working. Let's say physical therapy and all those things are not working. Quality of life is really bad. Or in a person who has cancer, I mean, their cancer is growing or they're getting treatments which are causing a lot of pain. Then we use opioids. So the first opioid that came out in the world was morphine, right? That's something that they got from poppy plants. Then came the other synthetic opioids, the oxycodones, the fentanyls, and now we have many more. Methadone is used for other things like addiction. It's a very good pain medication. So that's the next line drug that we use. Next slide. So basically what this means is that for opioids to work safely and well, your kidneys and your liver, which kind of work on these medications to break them down, and once they are used, throw them outside the body, they have to be in good condition. So they have to be, we have to make sure that the kidney and liver are fine. Next. So this is kind of a busy slide, but I just want you to look at the red line up there. Let's say that I give someone IV pain medications, right? So when you give someone IV pain medication, it works right away. You see how it's the tallest, the red line just goes all the way up. Right? So basically this is going up because it works really fast, and it works really well, and it reaches its concentration really well. So this is really good. But then you see it going down, right? Then it goes down the red line, but it ends before the blue line and the yellow line, which are the oral and subcutaneous routes of like giving it. So basically the idea that this diagram is kind of trying to tell, it's kind of busy, is that when you get an IV medication, it works really well. It works really fast, but it gets out of your system also really fast. It doesn't stick around too long. Then you see the blue line. If someone is given a pain medication under the skin, the blue line, it's a little slower to go up. It doesn't go all the way up like the other ones, but it lasts longer than the red line. So it lasts a little longer, right? So that is how the subcutaneous route works. But now let's look at the yellow line. That's the most important line for patients because that's something that they do primarily. You see how it's going up, but it's not reaching all the way up like the red and the blue lines. So it is slow to work, right? Over time, it takes slow time, but it lasts the longest. You see that graph, yellow graph going down? It lasts the longest. So it may seem like it's not as effective as the IV. It may seem that it takes a long time to start working, but apparently it works longest. And it is something that patients can use for their benefit. They don't have to take their pills as often as they need the IV medication. So this is how this works. Next slide. So One of the things that we always worry about with opioids is what are the side effects, right? You guys should always ask about when a patient or when you get medication from your doctor, what are you going to get? So number one, you see right away, number one is constipation. Everyone gets constipation, never goes away, never gets better. This is something that you get out of all narcotics. As long as you're on them, you will be, for a lack of a better term, tight. It will be hard stools. It will be difficult to pass. You will be unhappy, right? And it's never going to go away as long as you're on narcotics. So the idea is that whenever we start someone on narcotics, we try to give them laxatives. We try to give them something like Senokot, something like Docusate, something like Colace, right? Senna. And sometimes if these things don't work, we think about other things like Dulcolax, right? We think about things like lactulose, things to make sure that patients go every day because it is a class action. This is something that anyone who's on narcotic opioid pain medication is going to be there. So whenever you get opioids, you got to get your laxatives. Always take them. Otherwise, you won't be happy with your doctor. You won't be happy with yourself. And your bathroom time may increase significantly or pull out a hemorrhoid, worse. The second thing that happens is nausea and vomiting. Thankfully, these things go away within a week of starting a narcotic pain medication. Usually these patients do feel better with nausea. A little Zofran or Cetron here and there, that can take care of it while it sticks around for a couple of days. Third thing that happens is sedation. Now, everyone gets a little sedated with narcotics. They get sleepy, they get tired. They are not 100%. I mean, they don't think sometimes is what they tell me. They don't think right. If someone can solve a puzzle in their head in like 4 seconds, it takes them longer time. They're not as sharp. So that is something that we see very often. And when we start seeing that, we have to cut down because the first thing that happens is people get sedated and confused. And then the worst thing happens, which is all the way at the bottom, which is respiratory depression. And that is when patients can die. Or if someone that uses opioids, they can die. So we always see patients, not patients, we always see, I mean, on television and hopefully not in real life, that when people push heroin or fentanyl, what happens is that the first thing that happens is that they fall asleep, right? And once they fall asleep, the next thing that happens is that they cannot breathe. They choke on their own secretions. So this is where opioid should always be prescribed by someone who knows what they're doing. They should be prescribed by someone who can continue to monitor you. And this is the exact reason why patients, they sometimes don't do well with opioids because they start falling, they start getting confused, they don't think right. And this is why we always try to make sure, as the New Jersey law goes as well, that patients who are on narcotics have to be seen very often. So that is what we are doing. Some people get itching too, but that is something that sometimes goes away as well. Next one, next slide. Rules and regulations with opioid. Okay, so now this is important, and this is probably the most dynamic part of dealing with pain medications, and that is something that I get the most questions about. So the first thing is that anytime you go to a physician, always tell them that you are on a certain narcotic or certain opioid. Doctors and physicians and healthcare facilities and pharmacies and law agencies, they have access to everyone and their narcotics. We can see what someone has been given, where they have been given, and how they have been given, and when they have been picked up. So whenever I see a patient, I always look at that data for every patient on every appointment. And this is something that New Jersey State especially requires us to look at before we prescribe something. In addition, what I tell people about is make sure that you're alert. Do not drive with these pain medications. Make sure that you are not falling. Make sure that you're not confused, you're not sedated. You don't get respiratory depression that we talked about, not able to breathe, right? We talk about keeping these pills in a lockbox, making sure that you are not you're not giving access to someone else. If you lose them, there are two things you have to do. You have to file 2 police reports. First is for breaking and entering. Someone has broken and entered into your pain medication. Second thing is that someone has taken your narcotics, which have a street value. So be very clear that don't tell people that you have them in the house, cleaning ladies, other people's coming in the house. I mean, your own nephews, nieces, anyone. You are responsible for them. So that is a huge responsibility. You cannot drive with them. I always tell my patients, do not drive. I tell patients that whenever I give them opioids or narcotic pain medications, I tell them that you need to have naloxone at home, Narcan at home. God forbid if there is an incident at home where you get confused or sedated before respiratory depression happens, you give yourself that shot before 911 even gets there. I tell them that. I tell them that you are responsible for these. If you lose them, we are not going to refill them. If you overuse them, we are not going to refill them earlier because there's a responsibility that comes with this. So yes, some doctors are sticklers, but there are rules that have been put in place, especially over the last couple of years with the huge number of deaths that we're seeing in the country. So these are very important. I always tell patients that if you need a pain medication, it has to be done in an appointment. We don't refill on the phone, we don't refill on the weekends. And this is probably some of your pain doctors who are doing this as well. So the idea is that they're not being difficult, they are just bound by laws and regulations and safety for their own patients why they do that. All right, next slide. And hopefully this is, okay, so other things that we can use, we've already talked about that, right? So Tylenol, we can use the Aleve, NSAIDs, topical local anesthetics like lidocaine, aspirin, steroids, antidepressants. Remember when I talked about the connection in the brain? Antidepressants and anti-anxiety medications sometimes work really well for some people's pain. Antiarrhythmic medications that were used for the heart, they work really well. Non-pharmacological treatments like physical therapy, massage, acupuncture, Reiki, guided imagery, all those good things that Maura will talk about, they work really well. Next slide. So now, final thing that everyone asks me, what does CBD and THC do? Does it help with the pain? Does it not help with the pain? Which one works the best? Which one doesn't work the best? So the answer is, so CBD and THC are components of cannabis plant. So when cannabis is extracted, it has these two components in them. One of them is CBD, the other one is THC. CBD is the less potent one when it comes to the pain. So what you see on Amazon, on Walmart, as you walk outside, everything says CBD, right? Doesn't do a whole lot for pain management. It just does not. But then since it's a pretty benign thing in most cases, so what happens is that it doesn't have a lot of side effects either. Some people may get a little sleepy. Some people can have some improvement in their mood here and there, but it doesn't do a whole lot. So that brings us to the second component, which is the THC, tetrahydrocannabinol. Now this THC is the active component that in cancer patients makes them want to eat, makes them have slightly better mood, controls their nausea. So these are the first three things that it has been approved for use in cancer patients, or the states ask for before we prescribe them for a cancer patient. Now the other part is, does it help with the pain? Now that is subjective. Now there are studies which have shown that it works really well for pain. I've seen a couple of videos on Facebook. I've seen a couple of things on social media, Instagram videos, TikToks, right? All those things. I've seen them work amazingly well. Someone smokes a joint and feels really great. Well, in real life, unfortunately, I've not seen them. And these things have not been replicated in a lot of trials either. So if someone is in a lot of pain, they have used 18 different medications, nothing has worked. Yes, you can try medical marijuana. Yes, that is an option. That's the CBD THC ratio is what they look for. But the chances of improvement, as we have from the studies, can range from 10% up to 30 to 40%. Most people do not, unfortunately, get benefit, especially with cancer pain. For cancer pain, you need the real deal, the real opioids, because there's something pushing on somewhere in your body. But on the other hand, THC can sometimes help a little bit with some people's diabetic neuropathy. It can help with certain people's mood in certain places, help them eat better, improve their mood, so they can have a generalized feeling of well-being. But as a pain medication, if I were to say something like, well, THC worked really great for pain control, I wish I could say that. Unfortunately, that has not been the case from the studies or from our own practices. We wanted it to be the miracle drug, and unfortunately, it's not. So that's my part, and I took more time, I'm sorry. So I will hand it over to Maura Goetz, who's awesome. So Maura, take it over.
Hi, everyone. This is Maura. Thanks for joining today. Thank you so much, Dr. Habib and Alicia, for putting all of this together. So Dr. Habib really went into all the details about everything that we have here for you at CINJ to support you through your cancer treatment. You might be a survivor that's dealing with chronic pain, and we're kind of your one-stop hub to assist you and guide you through this. So there's also a lot of other ways that we want to support you other than just the medications. I just want to point out that this says integrative approach. So you'll hear out in the world, on the internet, on Facebook and everything, that there's alternative medicine. So I just want to be really clear that what we want to provide you is an integrative approach. So your medications, the side effects, your visits with your doctors, your visits with your nurses are so important. And those are a priority for you on your journey. But there's also a lot of other non-invasive or non-intrusive ways of managing your pain that you can learn to do on your own, or you can come to different groups that are available, support groups, where you can have guidance on these. So we can go to the next slide to talk about that. So mind-body therapies. A really basic one that works really well for pain is deep breathing. So there are a ton of YouTube videos out there, free apps that you can download, just basic education to teach you about deep breathing. And the more studies and science that is coming out on deep breathing, it's really just proving some ancient techniques of slowing your breath. And this is truly a relaxation technique. So, for our patients that are in acute pain, you'll experience maybe your nurse or physician, talk to you about taking some deep breaths, and that's just to take the edge off, right? So we're not expecting you to take deep breaths to take off the major cancer pain that you're experiencing. What we really want for you is to learn deep breathing techniques to help support you as you go through your treatment or post-treatment. Guided imagery. So what guided imagery is, in case you haven't heard this term before, is you can listen to, like I said, a talk or a YouTube video where a voice is actually guiding you through a specific scenario, which is going to really take you out of the situation that you're in. It can be a really beautiful form of distraction. So if you're going into that MRI that you have to go into every 3 months that you can't stand going to, or your PET scan, your CAT scan, your treatment, whatever it is, that's going to cause you some fear, anxiety, maybe you're in pain just laying on the table, you can put on a set of headphones and listen to basically a story to bring you into a really beautiful place. And there's a variety of these options for you. And at the end, I'll give you some resources of different things that you can choose from. And maybe your favorite place is out in the mountains, or maybe it's on the beach, and you can utilize these talks to just bring you to that space. So same thing with music. So if you're going for a test, maybe you're sitting in the waiting room to see your physician, when your mind is focused on your pain, that's where your primary focus is, right? So something that is going to bring you into the present moment, bring you into positive thought. Maybe it's an old song that gives you a reminder of a time when you were feeling a lot better in your life. Whatever that might be. There's, of course, tons of music out there and channels on Pandora and Spotify that's Zen sounds, something that's just the rolling sounds of the ocean. So these are ways to distract your mind from the focus of the pain that's causing so much challenge in your life. Prayer and mantras are also really, really beautiful uses of distraction for your mind. So that's bringing your mind into this, for mantras, it's using a repetitive concept that works for you today. So whatever that might be. And if you have a spiritual practice or you have a religious practice, reaching out to someone in that community that can guide you through prayer and mantras can be a really beautiful resource for you during your journey. That's something that can certainly help with pain. So that might not be something that we talk about all the time when you're coming in for your visits, and you have to go to the, like I said, you have to go to your scans or your chemo appointments or whatever you might be going for. But I just want to point out it's a wonderful use. So meditation, I know that we hear a lot about meditation now. Mindfulness-based stress reduction, that's a form of meditation. Again, there's free apps, and I will provide those to you, but there's lots of free resources to learn about meditation, and it doesn't have to be complicated. It can be really simple, and there is tons of science out there now that is supporting how this can help decrease your pain level. And this is something that can be supportive to you at any time of the day. So, you don't have to be here in a visit for us to be, treating you or holding your hand. You can do this on your own and have some empowerment during your cancer journey, that you can take some control over the pain and difficulties that you're dealing with. So cognitive behavioral techniques. So that's talking about talk therapy, essentially. So recommending that you speak with a social worker here at CINJ. They can work with you on different techniques, having a conversation about the pain and stress that you're dealing with, talking to Dr. Habib about the pain and stress that you're dealing with, your nurses. We're all available to help you. But there's really specific techniques that mental health counselors and therapists have learned to be able to utilize with you, so that you can utilize that to combat your pain and stress as well. So it's really worth looking into all of those options to help assist you through this. And we can go to the next slide. Okay, and movement therapies. So yoga, very popular like meditation. You've probably heard a lot about this out in the world. There's all different kinds of yoga. You don't have to be young and flexible and stand on your head to do yoga. That's not what it's all about. It's about relaxation, decreasing stress. And, Dr. Habib talked about how physical therapy is really important. Yoga can be a form of physical therapy. Sometimes you go to these physical therapy visits, and they give you an outline of things to do, and they actually give you some yoga poses to do. Chair yoga is a great option. Here at CINJ in the upcoming months, we're going to be offering a virtual chair yoga class. There are resources within your community that are virtual right now, where you can also learn some of these techniques. Qigong and Tai Chi are also movement therapies. These are also available out in the community. So I know that local YMCAs, recreation centers in your communities, the American Cancer Society, if you look some of these things up, you'll find that there's a lot of resources available to you that you could start kind of learning some of these techniques that can help you through your treatment. And then we can go to the next slide. So natural products. So, aromatherapy is something that can help you during your treatment and after. Thanks for moving the photo there. Having a diffuser at home is, you can get a really inexpensive diffuser for $12 on Amazon. You can get some pretty inexpensive essential oils. I put up 3 names in this slide just to give you some ideas. Lavender is a very popular and de-stressing scent. and it can be available in diffusers. Sometimes you see in different shops that they sell, they're in the pillows that you put over your eye. So, you know, if you're having pain or discomfort, there is science behind this, that lavender has been proven in some studies to decrease some of that pain. So these are just other resources that you can add in to your entire pain regimen. And we can go to the next slide. So energy therapies. You may or may not have heard of this. So when we talk about Reiki therapy, healing touch, therapeutic touch, what this means is that you have a practitioner that meets with you, and it's really a non-invasive technique where they hold their hands over different parts of your body and move energy throughout your system. So if you've ever gone for a massage of course is, you know, a hands-on, can be invasive. If you're going through treatment, you normally have to get approval from your oncologist, because you can't be maneuvered in certain ways. The beautiful thing about Reiki and therapeutic touch is practitioners that provide this are normally nurses, social workers, physicians, yoga teachers. They're all different resources of people that can meet with you. I know we're, you know, experiencing a pandemic, but there's also virtual ways of providing healing touch and energy therapies. And these have been available for many, many years. And if you've been in and out of Robert Wood Johnson, or maybe the Livingston location, there's actually a nurse that will come see you on site and provide those therapies. Acupuncture and acupressure. So acupuncture is when they actually utilize that little tiny needle. And Dr. Habib showed an image way in the beginning of all of the nerves in your body, right? So actually, acupuncture has been shown to improve cancer pain and side effects. I know that it's still kind of up in the air whether insurance companies will cover it or not, but we're definitely, you know, that's been an uphill journey, I think, for many years, but now we're seeing a lot of clarity in clinical studies. And acupuncture can also be resourceful for patients that experience peripheral neuropathy. That's a really common side effect. We have a resource here at Rutgers. We'll give you some of that information at the end. And then also, as I said, there's lots of practitioners that you can see for these appointments. Acupressure is also using a light touch for certain spots in the body. Some can be for nausea, some can also be for pain. And then we'll go to the next slide. So more manipulative therapies, like I mentioned, massage and reflexology. So massage is going to be a little more invasive. You are going to want to talk to your oncologist to get a clearance. There are massage therapists that specifically work with oncology patients. And, you know, this is something that is just looking at the picture, right? Doesn't that look beautiful? Don't we all want to be laying near some really nice low lights in a spa-like setting and receiving a massage with some lavender aromatherapy? That sounds like it would, you know, it would really improve pain. And I'm making a joke, but really it is something that you do have to talk to your oncologist about in advance. And it's a hard time right now in COVID, of course, to go somewhere for a massage. But these are techniques that down the line, if you're in your survivorship, and they're ways of de-stressing as well. And we can go to the next slide. So ask to speak to your social worker. Our social workers will talk you through guided imagery. They will give you free apps. As I said, cognitive therapy. If you go to our online resource, it actually has a ton of listings. So this is our cinj.org. We have Mind Body Techniques. We have our own YouTube channel, which also has some really calming Zen music that's free to anybody to use. Our librarian made it. If you're here at CINJ, you're here for treatment, you're here for a visit, you're here to see Dr. Habib, ask to speak to the librarian. She is available and she wants to provide you all the resources that are going to help you. So thank you so much for tuning in today. And I think we'll switch over to questions. Thank you so much and good luck with everything, everyone.
Thanks, Dr. Habib and Maura. Great job. I do have some questions in the chat. Maybe I can read them and whoever's applicable can answer. Sound good?
Perfect.
Okay. What are the steps I need to do if I misplaced my prescription for an opioid? Will my provider provide me another set of prescription?
That's a very good question, and that's a very valid question under the scenario that we just discussed. So there are two parts to this question. Number one, what can I do? So if you misplace your medications, definitely you unfortunately have to file a report with the police that you've lost this. Most pain physicians require that report to be part of their records as well. The other part of this question was that should your provider give you again that prescription? That's a very good question. So what happens is different practices are different, but the way it goes is most of the providers are not able to prescribe you the medication for two reasons. Number one is because if your insurance is paying for a certain amount of medication every month and you take a new prescription, the insurance will not pay for it. So let's say if you do agree to pay out of pocket for it, what happens is that it goes as record that this is something that was lost. So a lot of people, what they say is that be very, very, very careful with your medication, like with your jewelry almost. Make sure that your prescriptions and your medications are in the same safe hands, because it's in certain cases almost impossible to refill those prescriptions because of different logistical and almost legal issues that come out of narcotics, unfortunately, where deserving patients are squeezed because there are other people out in the community who are doing things which are not supportable.
Okay, I have another question in the chat. And again, if anybody has any questions, please ask in the chat. If one uses narcotics for years for chronic pain, am I at higher risk of difficulty coming off the meds and possibly need rehab to discontinue them?
Excellent question. So again, two parts of this question. Number one is that if you've been on a medication too long, would it be difficult for you to come off? So depends on, again, going back to the slide, the patient factors, disease factors, and the drug factors, right? So we know that opioids do cause a withdrawal and it's difficult. Now, the other question is that if you're taken off this pain medication, would your pain be really worse, right? So if that is the case, that would be difficult for you to come off of it. The third part of it is that the patient factor, that everyone is different. There are certain people who can come off a huge amount of pain medication and not have a lot of withdrawal, but most people fall in a place where they do have some withdrawal. So this brings us to the second part of your question, which is that do you have to go to rehab? Now that's a good question. Every person is different. When patients come to me and they want to come off of these pain medications, which in most cases is doable, there are different processes to do that. Number one is that you can cut down gradually this medication. Take off the Band-Aid gradually. See how you do. Add other medications for your pain to make sure that you don't have a lot of pain. The second part is that the second way of doing it is that we can actually take the Band-Aid off real fast. Some people get a lot of issues. So anyone who's using more than 100 milligrams of morphine equivalent, I usually taper them off gradually over, I would say, 3 to 4 months. If they are having a lot of issues, then yes, things like Suboxone, things like buprenorphine clinics, outpatient clinics, they can provide the medication and the support that you need to gradually come off these medications. In most cases, you don't need inpatient rehab where you have to get admitted. The outpatient support services are actually pretty good these days. In the place where I practice, I work with certain facilities in the vicinity who have been excellent in providing care for our patients. But I usually leave that to someone who's an expert, who does this on a regular basis and who can follow up on these things from a quote unquote dependence and addiction standpoint. And again, I want to add one more point here, is that not every person who's dependent on their medications is an addict. These are two extremely difficult terms, and unfortunately, they are often overused and commonly used and overlap. That is not the case. Only a specialist can tell you, addiction specialist can tell you whether you have issues which make you liable to be an addict versus being dependent, which means that you just need it for your symptoms.
Okay, thank you. Next question is it true that some people have a higher tolerance for pain than others? And is there a difference in pain tolerance or perception with gender?
Very, 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 very loaded question. Good question, but very loaded question. I don't know how to squeeze myself out of this. The answer is that everyone is different. Everyone's circuitry, remember that first diagram, the brain diagram, everyone's circuitry is different. Everyone responds different to pain medications. Everyone has a different tolerance. It's so subjective. I wish if I had pain medications and I could do 2 + 2 and bring out a 4. It doesn't happen. When I put 2 and 2 together in a pain medication patient, sometimes it's -37 and sometimes it's 3 million. You never know what you're going to end up with because human body has so many things happening. All that circuitry in your brain, right? Everyone has different tolerance. Now the question is, does it matter or does it affect a gender affecting it? And the answer is different studies have shown different things and the results are always mixed. Now it's easy to generalize and make a statement that XYZ has more pain, but that won't be correct or supported by any sort of research at this point, at least from my understanding of what I've read. But that being said, we know that age is a big factor when it comes to perception of pain. So you know how little kids, they bang their knee and they cry for 3 hours, right? So that is because they get scared. There's an anxiety component to it. There's a fear component to it. And they perceive pain more, right? Compared to older people who have arthritis in every joint in their body, and they are just walking around and not have a lot of pain. So we know that age does play a part. Younger people, unfortunately, when they have cancer, they have worse pain than some of the younger patients that we get. So that would be one of the things that I would kind of say that age plays a part. Gender, I think the studies are just it's hard to make a comment on that. And Maura, please go ahead. I mean, I want to see where you come off on this. How do you see this?
Yeah, no, I agree. I think that it's really hard to come to a conclusion. And, you know, we see patients with all different types of cancers and all different ages here at the Cancer Institute. You know, we see people that have some pretty rare diagnoses that are going through clinical trials. So, you know, the overall out there in the world, clinical trials, you know, there isn't one conclusion. But I think that's a great question. And I think that it's something that you can certainly be open to having communication with your physician about also when you come in for your visit. You know, is the pain I'm experiencing quote unquote normal for my diagnosis? Because sometimes we're concerned about the progression of your symptoms and we need to know that your pain is changing, it's getting worse, so that you can be appropriately assessed and that we can, you know, treat you to the best of our ability.
Thank you. Dr. Habib, you're on mute. I have another question. Can patients from other locations access pain medication or palliative care services at CINJ?
Very good question. The answer is yes in most cases. In certain cases, I like to have records available before I treat someone, especially when it comes to cancer pain management. I want to know what is the latest thing that is happening with the patient. I want to know what their other oncologists think about their pain. Palliative care services can be provided to people, granted they meet certain criteria. I mean, yes, they are available, but we do it on a case by case basis because there are certain services that we have that work very well for certain patients at CINJ. And like I said, I mean, some of our facilities, some of the things that we do, we kind of outsource them, like issues with tapering down medications or medications that are difficult to come off of. So those are the services that we don't have. So the better answer would be yes. And again, on a case to case basis, depending on what the symptoms are and how much we can help those patients in the best way that they deserve to be helped or assisted.
Thank you. Another question, will I be prescribed naloxone when I start on opioids?
Good question. Again, this is something that has happened recently. So Governor Murphy about 6 months ago signed legislation on in New Jersey patients specifically that whenever you get a narcotic prescription, you should have Narcan or naloxone available at home. This has been signed into legislation recently. So not everyone does this, but this is something that we expect people who stay up to date with legislation, they would do that more often. And even if you go to your pharmacist, there's a good chance that your pharmacist will tell you about it. Or if it's not been previously prescribed, you can actually get it without a prescription as well. They can give it to you and even tell you and teach you how to use it most effectively. So the answer is, if you're in New Jersey, you should definitely be getting a Narcan prescription, or if not, you can get it from a pharmacist and be told on how to use it most effectively and safely for any unforeseen conditions.
Great, thank you. Another question. I am a triathlete and exercise 7 to 10 hours a week. My cancer is on the bottom of my foot and extends to my groin. Lately, my calf, where there are minor tumors, has been hurting mildly. How can I distinguish the cancer pain from fatigue or overuse? Should I stop exercising if the pain continues?
First of all, kudos, man. I mean, you work out more than me. So this is the 7 to 8 hours a week. That is amazing. I mean, I can barely get 30 minutes on a treadmill. So the answer would be that it is hard to say what is causing what pain, and coming to a clinic and seeing a physician for it would be the best way. I would not want you to hold your exercise because you're in pain. One of the things that you can do, just diagnose yourself. It's cut down on a couple of days of exercise and see if that helps. I mean, in certain people, 7 hours or 8 hours a week may be excessive. So everyone is different, going back to that statement, and that is my alibi here. Everyone is different. You cannot generalize how each person is, but you can kind of experiment with yourself. I would not tell you to not exercise, but everything in moderation is always good. If you think that your body tolerates 30 minutes of exercise 5 times a day, that is what your limit should be. Yes, exercise, if done excessively, can cause worsening pain, but when you have cancer in the same site, they have to be differentiated. I would say definitely see your physician, see what they think, but also just experimenting at home and seeing how do you do with cutting down some of the exercise may be an easy solution at home. And Maura, if you have something to add, I mean, please.
Yeah, no, I think that telling a triathlete not to exercise is probably one of the hardest things, right? I mean, that's your, my mother-in-law was a very successful triathlete, and getting her out of the ocean was close to impossible in her late 60s. So I've had experience with that. And, you know, I think finding the balance, you know, what Dr. Habib said about, you know, it's going to be different for everyone. And part of, you know, your exercise is physical and part of it is mental. So everything that you can do for yourself to maintain the clarity in your mind that you achieve from those really, really long hours of swimming and running and biking. And there's going to be some that are going to be less impactful on your body. So certainly talking to your primary oncologist about those, you know, very specific movements that your body is taking. And then, you know, also just being open to other ways of moving your body that maybe you haven't done in the past. You know, of course, I'm a huge proponent of yoga, and it doesn't have to be an aggressive, you know, the room doesn't have to be 110 degrees and you don't have to do a handstand, but it can be a way of moving your body and clearing your mind that you achieve through your runner's high and through your, you know, all the work that you do in your triathlon. And all of that stuff is going to make you more resilient during this challenging time. Thank you.
Thank you. I'm going to open up the floor. If anybody wants to unmute themselves and ask a question, you can do so now. Does anybody want to unmute themselves and ask a question? I don't see any more questions in the chat. I guess not. So thank you very much, Dr. Habib and Maura. It was wonderful. And I would like to put into the chat to take a survey and let us know what you think about our presentation today. It would be much appreciated if you could answer the survey. I'm putting it in there now. And one last chance, if anybody has any questions, I'm looking in the chat. You can unmute yourselves.
Wow. Hello?
Yes, go ahead.
Oh, I didn't know. I couldn't figure out. My computer is out
Sure.
of date, so I couldn't get on. So I'm trying to do it from the phone. I didn't know if I was muted or not. I went through chemo 5 years ago, and I ended up with neuropathy in my feet. And I've been to multiple doctors, and I don't know if there's anything natural I can do for that. They basically, I feel like I'm being told you just got to live with it.
Yeah. So earlier in the talk, I mentioned acupuncture. So acupuncture is a form of utilizing really, really tiny needles to move the energy in your feet. So it's actually been shown in studies that it helps with some improvement. I have certainly talked to acupuncturists about utilizing this form of work for patients that have peripheral neuropathy post-chemotherapy.
Okay.
You know, in some cases, it might only help a little bit, and you might have to go to many sessions. That's generally how acupuncture works. It's not kind of like a one-time visit. It can take sometimes, you know, 6 to 8 visits. But, you know, if you have an acupuncturist you really like, you get to chat and have a great visit together and start to feel better over time. Again, this isn't something that your insurance is necessarily going to cover. But there are resources for that in the local community. And I can maybe message you because I could give you some resources, but I don't want you to tell me too much information with everybody on here. So why don't I message you some more information, okay?
Okay.
Can you email me? It's Alicia. You've seen a few emails from me?
Yes, that's why I was late. I was trying to get my computer, but it wouldn't work. So I finally got my phone to at least get on my phone.
Yeah. Just email me your name and your contact information, and then Maura can give you some more information.
Yeah, that would be great. Yeah, I would be happy to help you with that.
I'd like to ask a question too.
Sure.
Sure.
I'm having the same problem that this lady just spoke about. So I will email Alicia too, because I had breast cancer and now I'm dealing with my feet feel like they belong to somebody else.
Oh, yeah.
Yeah.
Yeah, we can certainly give you resources within Rutgers and outside of Rutgers. And it's certainly worth looking into in a little bit more detail. And I know our oncologists here in the breast group are supportive of acupuncture. It's something that we've certainly discussed here and offering it in the future when we're not under COVID here at CINJ, and we'll be happy to share that information with you.
Okay, I'm from
I've
New
heard
Jersey,
good things
but
about it. I've heard good things about acupuncture from people.
okay.
There actually is an office near where I work in Metuchen, so. All right, thank you.
Maura,
I'm from New Jersey, but I live in South Carolina now, and my daughter sent me the invitation. Actually, I'm just really getting on because I forgot. But
Well,
the
thanks for
last of
joining.
huh?
Thank you for joining us.
Yeah.
So listen, guys, everyone, you guys are fighters. You guys are doing an amazing job. So proud of everything that you guys do, staying active, fighting this cancer, survivors and thrivers. Okay, that's how we do it over here at CINJ. Survivors and thrivers. Congratulations, you guys are rock stars.
thank you. Moira, I could use
Thank you.
that information as well.
Okay, so just email
This is
Alicia
Mary Buck.
your info, and then
Oh.
we'll send you that. You have Alicia's email in there?
Mary, I can email
Where would
you. I
I-
have your email, okay?
Okay, dear,
And then you'll
thank
just
you.
reply to me,
Thank you.
okay? Yep.
Do you have mine? My daughter, she invited me. Her name is Erin, but I'm Louise Watt.
Okay, Louise.
Okay,
Thank you.
thank you.
Anybody else have any questions?
Yes, I do.
Great.
Hi, Odessa. My name is Robert Lucenta. I recently had a stem cell transplant, actually coming up on 100 days. And I've had the worst
Congratulations.
pain. Thank you. I've had the worst pain in my neck, like trying to sleep, like in my shoulders and my neck. And I tried aspirin and, just basically can't sleep at night. And it stays in the day. I can't reach my arm over my head. So I talked to Dr. Shah about it, and he said to see an orthopedic surgeon about it. But I just was wondering, did anybody else have this problem from the transplants in their neck and shoulders?
So I can give you the answer to it. So people who get transplants, they get a lot of new symptoms. Sometimes these symptoms are very different from symptoms that other people get. And in addition, as we get older with time, our bones and our joints are not as great, and we can have new pain syndromes, which can be further worsened by getting transplant or medications with transplant or the long-term effects of it. I know Dale Shar is a wonderful, wonderful physician. You are in good hands there, number one. And the second part is that if the pain gets worse, tell Dr. Shar, and we work together, we can try to come up with some ideas on how to best deal with your pain. It should not be a problem. We can improve quality of life for a lot of people, especially bone marrow transplant patients.
And your name, Doctor?
My name is Dr. Habib.
Dr. Habib. They said something about like they wanted to give me creams, and they said to be careful with creams because some of the creams can have adverse effects with your medicine.
That is correct. So
Yeah.
like I said, remember that third slide, that there are three factors to a patient's pain medication selection, the patient factor, the medication factor, and the disease factor. So we have to look at all of these things. So definitely tell Dale, you're in very capable hands. We are more than happy to assist with anything we can. All right.
Okay.
You're in good hands, man. You're in a good place.
Thank you, sir. Thank you so much, Doc.
I'll send out an email, a follow-up email to everyone too, with a copy of the slides. And if you do think of any questions, just let me know, and I can forward those on, and hopefully we can answer them for you.
Okay.
Thank you.
Okay.
Anybody
Thank you.
else? Okay. Thank you,
Great.
everybody.
Everyone.
Have a good evening.
Thank you.
Thank you,
Take
you
care.
too.
Thanks,
Bye-bye.
everybody.
Bye-bye.